So, hello everyone, and on popular demand, welcome to another A Day with Me session where I'll take you through all the cases that I have seen today, along with their reports and some discussion. So, starting with our first case of the day, so here we have a 60-year-old female with complaints of dysphagia and gastroesophageal reflux. So, this is the topogram of this female. On the basis of the chest radiograph, she was advised a HRCT. So, this is the topogram where we can see that there is mediastinal widening along with the deviation of the trachea towards the right side. So this is the CT scan of this patient. So this is the non-contrast axial section from cranial to caudal direction. We can see that this esophagus is dilated, and we can see some part of the stomach, the axial section within the thoracic cavity along with some mesenteric fat. These are the coronal sections, plain non-contrast CT. We can see some fat along with herniation of the stomach into the thoracic cavity and dilatation of the proximal part of the esophagus. So I got a contrast scan done for this patient, and these are the axial sections post contrast where we can see this air fluid level dilated esophagus, and this is the normally enhancing gastric folds within the thoracic cavity that is seen. So dilated esophagus, grossly dilated esophagus along with the part of the stomach that is herniating through the esophageal hiatus. This is seen in the sagittal section along with some fat that is herniated within the thoracic cavity. So the mucosa and the gastric folds were normally enhancing. There is no mass lesion that is seen. So this is the report that I had given. The gastroesophageal junction in the stomach along with some intra-abdominal fat was seen to herniate through the widened esophageal hiatus. So important to mention the diameter of the esophageal hiatus. And the gastroesophageal junction lies about 5.2 centimeters above the esophageal hiatus. This is an important point to be mentioned to the distance of the gastroesophageal junction from the esophageal hiatus, along with some dilatation of the proximal part of the esophagus that was seen as mediastinal widening on the topogram. And there was no abnormal enhancement in the wall of the esophagus or the herniated stomach. So features were suggestive of a sliding type of hiatus hernia. So hiatus hernia is basically of two types, sliding type being the most common. The other type is rolling hiatus hernia. And hiatus hernia occur when there is herniation of the abdominal contents through the esophageal hiatus of the diaphragm and into the thoracic cavity. The most common content of the hiatus hernia is stomach. Sliding hiatus hernia is the most common type of hiatus hernia. The gastroesophageal junction is usually displaced more than 2 centimeters above the esophageal hiatus. And the normal esophageal hiatus is often abnormally widened in such cases. In fluoroscopy, it's an important criteria that more than 3 gastric folds are seen above the hiatus, suggesting sliding hiatus hernia. The gastric fundus may also be displaced above the diaphragm and present as a retrocardiac mass on chest radiograph. The presence of air fluid level in the mass suggests the diagnosis here. The dysfunction of the lower esophageal sphincter and the presence of pathologic gastroesophageal reflux are crucial factors in producing symptoms and causing complications. So the complication of a hiatus hernia include a tension gastrothorax. So this is actually a tension gastrothorax, which describes a rare life-threatening condition caused by mediastinal shift due to distended stomach herniating into the thorax through a diaphragmatic defect. And another important complication is Cameron lesions. Cameron lesions are usually diagnosed on endoscopy, and they are actually ulcers or erosions that occur on the mucosal folds at the diaphragmatic impression of the hiatus hernia. And another important complication is gastric volvulus. So coming to our next case, so this patient presented with chronic cough and fever, and we got HRCT done for this patient. So these are the axial sections, lung window, where we can see this large cavity along with some soft tissue density mass within it. Multiple such cavities are seen in the left lung field along with some volume loss and mediastinal shift to the left. This is the mediastinal window. Again, we can see that this mass lesion in this post-contrast image is not enhancing, and multiple cavities along with the soft tissue density mass is seen. So we can see this is in the posterior aspect of the cavity in this section, in the supine position. So always we have to get a prone scan done in such situations. where we can see that this prone scan, this soft tissue has shifted downwards. You can see it is here, the opposite side of where it was in the supine position. So it's actually shifting with the change in position. It's the left lung field. So this is the report that I had given. Multiple well-defined cavitating lesions were observed in the left lung field, and all the lesions demonstrate intracavitary heterogeneous non-enhancing soft tissue with surrounding air crescent and a thick homogeneously enhancing wall. The soft tissue density actually changed position within the cavity on prone scans, which was suggestive of Monod sign. And there was some interlobular septal thickening and ground glass opacities were also seen surrounding these cavities, and multiple centrilobular non-enhancing nodules were also seen in the posterior basal segments of the left lung. So features were suggestive of a fungal aspergilloma. So aspergillomas are basically mass-like fungus balls that are typically composed of Aspergillus fumigatus and a non-invasive form of pulmonary aspergillosis. So they occur in patients with normal immunity but structurally abnormal lungs with pre-existing cavities. So this patient has a history of tuberculosis. So because of that TB in the lung, there were cavities that were formed, and this Aspergillus fumigatus got lodged in those cavities as fungus balls. So TB is the most common, accounting for 25 to 80% of the cases depending on the prevalence of TB in the population. Other than that, it can be pulmonary sarcoidosis as well as bronchiectasis from any other cause. So coming to this important sign, that is the Monod sign. Monod sign describes the gas that surrounds the fungus ball in the pre-existing pulmonary cavity. It is different from air crescent sign. It implies a freely mobile mass which moves on mobilizing the patient. That is, on prone position, it changed its position. So that is called Monod sign. Air crescent sign is typically seen in recovering invasive aspergillosis. So coming to the third case of our day, so this patient presented with low backache and we got an MRI done for this patient. So these are the T1 weighted images, sagittal sections, where we can see there's some heterogeneous signal in the T12L1 level. These are the T2 weighted sagittal sections where we can see a heterogeneous lesion at the T12L1 level. So we did a contrast scan for this patient. So these are the T1 post contrast sagittal sections where we can see this solid cystic heterogeneously enhancing lesion at T12L1 level. To see which compartment it belongs to, we have to see the axial images. So this lesion is actually causing compression of the cord. It's an intradural extramedullary lesion. These axial sections, post contrast images, we can see some extension into some enhancement of the nerve root as well that is seen. So this is a report that I had given. A well-defined intradural extramedullary heterogeneously enhancing solid cystic lesion from the upper border of D12 to lower border of L1 vertebra craniocaudally. The heterogeneous post-contrast enhancement of the solid components was seen. The lesion was causing displacement of the conus and the cauda to the left, and there was mild enhancement that was noted at the exiting nerve root on the right side. So features were suggestive of a nerve sheath tumor. So the two most important nerve sheath tumors are schwannomas and neurofibromas. Schwannomas are frequently associated with hemorrhage, intrinsic vascular changes like thrombosis, sinusoidal dilatation, cyst formation, and fatty degeneration. These findings are rare in case of neurofibromas. Neurofibromas tend to encase the nerve roots in contrast to schwannomas, which commonly displace the nerve root due to their asymmetric growth. Schwannomas are usually round, whereas neurofibromas are commonly fusiform. An important sign that has to be noted is a hyperintense rim with a central area of low signal on T2, giving a target sign may be seen in neurofibroma and occasionally in schwannomas. This is thought to be because of the dense central area of collagenous stroma. The spinal nerve sheath tumors are the most common intradural extramedullary masses, and the nerve sheath tumors include, in order of decreasing frequency, spinal schwannoma, then neurofibroma, and then ganglioneuroma. Most nerve sheath tumors arise from the dorsal sensory roots, and 70% are intradural and extramedullary in location. So coming to the next case of our day, So here we have a patient who presented with severe headache and weakness, and this is the MRI done for this patient. So these are the SWI images, axial section, where you can see multiple foci of blooming in the cerebellum, bilateral cerebral hemispheres. There is a area of hemorrhage also in parieto-occipital region. Multiple areas are seen concentrated in the bilateral basal ganglia, typically, along with that hemorrhagic area in the right parieto-occipital region. That area of hemorrhage that is seen on T2 weighted images as T2 hyperintense, and the corresponding area on T1 is appearing hyperintense, suggesting a late subacute stage. This is the report that I had given. The hemorrhage was present, the late subacute intraparenchymal hemorrhage was present, along with multiple susceptibility foci scattered predominantly in the basal ganglia, brainstem, and cerebellum, which was consistent with chronic hypertensive microangiopathy. So, whenever we see this particular image, that is multiple foci of blooming, which is seen in the bilateral cerebral hemispheres, we have to think of two main possibilities in this old age. Either it can be a chronic hypertensive microangiopathy, or it can be a cerebral amyloid angiopathy. In this case, because he was having a bleed in the brain in the right parieto-occipital region, as well as the foci were concentrated mainly on the bilateral basal ganglia and the cerebellum, it is suggestive of chronic hypertensive microangiopathy. What exactly is cerebral amyloid angiopathy? Cerebral amyloid angiopathy is also a cerebrovascular disorder which is caused by accumulation of cerebral amyloid B in the tunica media and adventitia of the leptomeningeal and the cortical vessels of the brain. The resultant vascular fragility tends to manifest in normotensive elderly patients. So this is seen in normotensive elderly patients as lobar intracerebral hemorrhage. It is along with Alzheimer's as common cerebral amyloid deposition disease. So this typically does not have predilection for any basal ganglia or cerebellum. It is seen throughout the bilateral cerebral hemispheres, typically in the corticomedullary junction. So coming to our next case, this is an ultrasound case where we can see a bulky uterus that is seen with some cystic changes in the posterior myometrium. This posterior myometrium is asymmetrically enlarged as compared to anterior myometrium that is seen. This patient presented with a lot of bleeding and pain. The junctional zone is also not very clear, as we can see, and there is no mass lesion as such that is seen with any capsular vascularity. There is just translesional vascularity that is seen. So this patient is a multiparous patient. So what do you think the diagnosis is here? So based on this, the diagnosis here is adenomyosis, and Musa criteria is used for the diagnosis of this particular condition. Musa is actually morphologic uterus sonographic assessment. Says that if any two of these six features are present, we can confidently diagnose it as adenomyosis on ultrasound. So if the wall thickness asymmetry is present, typically more than 1.5 times, heterogeneous myometrium, poor endometrium myometrium transition, fan shaped shadowing, question mark sign, that is a retroverted uterus, and a translesional vascularity. If any two of these features are present, we can say that this patient is having adenomyosis. So coming to the basic differences between a typical fibroid and adenomyosis, so these are the important subheadings based on which the differences can be easily remembered. The serosal contour of the uterus, it's actually lobulated or regular in case of a typical fibroid, while it is globally enlarged in case of adenomyosis. The definition of the lesion, the typical fibroid is very well defined, while adenomyosis is ill defined in case of diffuse adenomyosis. Adenomyoma may be well defined. The lesion is round, oval, lobulated, hypo or hyperechoic with internal shadows in case of typical fibroid, while the lesion is ill defined with no rim or edge shadows and non-uniform echogenicity in case of adenomyosis. The vascularity is typically in fibroid is actually a capsular circumferential flow, while in case of adenomyosis it's translesional vascularity that is seen. Junctional zone is very well defined in case of a typical fibroid. In a submucosal fibroid, it may be focally ill defined, while it is always ill defined or thickened or interrupted in case of adenomyosis. Coming to our next case, which also is an ultrasound case. This patient is post C-section, 3 months now, She presented with pain in the abdomen, and this is the ultrasound done for this patient. We can see that this lesion is seen, the anterior myometrium, posterior to the bladder, at the scar site, some echogenic foci within. So what do you think the diagnosis is here? It's very clear. It's actually a bladder flap. So bladder flap hematoma is a hematoma between the uterus and the posterior wall of the urinary bladder, and it is usually small. It is physiological if it is less than 5 centimeters post surgery, and more than 5 centimeters is actually pathological. So this actually I have discussed in detail in my lecture on fourth trimester scan. It's there in Conference Spotters part 1. You can see that. So coming to our next case, so this is a CT case. This patient was unconscious, and this is the CT scan done for this patient. No history of trauma. You can see a large intraparenchymal hemorrhage, bilateral capsuloganglionic region. Few punctate foci of hemorrhage that is seen in the brainstem. Important point is there is midline shift, cross midline shift to the left side. Subfalcine herniation is seen, and these are the coronal sections where this uncal herniation is also seen. So this actually it's a very commonly seen case. I just put it to show you all the different types of herniation. So this is a report that I had given, and this also had some durate hemorrhages along with those intraparenchymal hemorrhages because of the subfalcine and the uncal herniation. So these are the different types of herniation that are seen: subfalcine, central, uncal, and tonsillar herniation. Where uncal and subfalcine herniation were seen in our case, because of that durate hemorrhages, that small micro hemorrhages that were seen in the brainstem in this case. So coming to our next case, this is a 6-month-old child who presented with delayed milestones, and this is the CT scan done for this patient. As seen now, a cross section of this case, multiple punctate calcium foci, periventricular, generalized brain volume loss, multiple calcifications, typically periventricular calcifications, volume loss, prominent ventricles, coronal sections, and calcifications. Based on this, what do you think the diagnosis is? Potter. It's a torch infection, which is CMV more than toxoplasmosis. So torch infections are toxoplasmosis, syphilis, parvovirus, rubella, CMV, HSV. Congenital intracranial CMV infection typically has periventricular calcifications, fetal hydrocephalus, microcephaly, and intraventricular adhesions, while in case of toxo, it is typically distributed throughout the bilateral cerebral hemispheres with no predilection to the periventricular region. Coming to our next case, so this patient present with a lot of bleeding, typically intermenstrual bleeding, and this is the ultrasound picture of the uterus. We can see this homogeneously echogenic intracavitary mass lesion that is seen in the endometrial cavity. And these are the color Doppler images. We can see that it is being supplied by this artery. It's called feeding vessel site. Intracavitary homogeneous mass lesion along with feeding artery site. It's typical of endometrial polyp. These are some features of the endometrial polyp on ultrasound, that is interrupted mucosa sign. The polyp focally interrupts the normal mucosal contour of the uterine cavity, usually solitary homogeneous echogenic lesion, a bright edge sign, and also it may mimic endometrial hyperplasia when it fills the endometrial cavity, but you can definitely differentiate it with help of feeding artery sign or vessel sign, which was seen in our case. where a single feeding vessel may be seen extending to the polyp on color Doppler. So coming to the last case of our day, so this patient has a history of injury to the neck 6 months back, and this is the brachial plexus MRI done for this patient. These are the coronal T2 weighted images, where we can see that there is CSF outpouching along the C8 and T1 nerve roots, along with some volume loss of the left shoulder girdle muscle. You can see there is some volume loss. These are the coronal stir images, where again we can see the CSF outpouching along the nerve roots C8 and T1. These are basically pseudomeningoceles. So I've discussed in detail about this particular uh, condition in one of my videos. You can take a look at that. So this is a report that I had given: pseudomeningocele due to nerve root avulsions of C8 and T1, along with denervation muscle changes in the left shoulder girdle musculature. So that finishes the day.